Disease in Childhood, Professor Karel Allegaert is a rare individual in that he is both a neonatologist and a pharmacologist. He's Professor of Clinical Pharmacology and Pharmacotherapy at the Catholic University of Leuven in Belgium, and a senior neonatologist at the Sophia Hospital in Rotterdam, the Netherlands. He's a member of the Royal Academy of Medicine of Belgium and was previously president of the European Society of Developmental Pharmacology and section head of clinical pharmacology for the ESPR. He has an impressive publication record, and his research is focused on developmental and perinatal pharmacology and neonatal and pediatric pain, which makes him ideally suited for the challenge we threw down to him as a society, asked him if he would very kindly give us a talk entitled Challenges of Evaluating Medicines in Neonates. Karel, welcome.
Thank you for your kind introduction. Thank you for the invitation. To be honest, when I got invited, I didn't know that Winchester actually existed. Sorry, it's politely meant. But my wife did some historical research, and she was quite interested in this region of the country. So, and despite some train strikes, we made it. So it's really truly an honor to be here and to discuss with you the topic on evaluating medicines in neonates. And I think the subheading already largely reflects the problem that we are dealing with. Limited in size, but extensive variability. And this makes it even more difficult to really do extensive assessment of drug and drug choices or dosing in neonates. I have nothing specific to disclose. And I would like to start with some of the conclusions, because it sets the scene of what I would like to discuss with you today. And the first aspect is something that you tend to forget when you're just working on your unit. But neonatology is by definition a profession or a discipline. We are working at the fast lane of developmental life. If you discuss with someone outside of the neonatology, they classify you, oh, you're taking care of the small babies. And that's correct. But within this size, you already have a tenfold difference, one log value, if you work between 500 gram and 5 kilogram. So being small is not exactly the same. And I was intrigued, for instance, in the former session in the 22, 23, 24 weekers, because again, do not misunderstand. These 22 and 23 babies are not just smaller 24 weekers. Even if you look at the needs on the pharmacotherapy, they are different. If they have hypertension, it's much more likely that it's adrenal mediated, and it's related to the immaturity of a cytochrome, which is needed to make your cortisol. So the mechanism of hypertension may be completely different. The incidence of pulmonary hypertension is significantly higher if we can believe the US and Japanese studies, who use much more common nitric oxide in these very tiny ones. So it's not just a smaller group of small babies, it's very likely another category of cases. And that's something that we have to realize. Second, drug clearance is low. That's not rocket science. But again, it's all about the variability. Is it 1% of adult value, or is it already 10%? So again, you end up with a lot of variability. So this means that we have to try to understand better why. What are the drivers of this variability? Are it characteristics until delivery, or are it characteristics after delivery? And if so, are they maturational or non-maturational? And how can we assess this to end up with dosing regimes which make sense and are also, for the clinician, doable, because it cannot be too complicated to really do it right. And obviously, there's no such thing as a neonatal liver or a neonatal kidney. There's a baby that you have to take care for. And this means that, for instance, a liver may mature in a completely different page compared to kidney. So that for a given drug with a metabolite, that actually the baby can indeed clear to the metabolite, but cannot yet eliminate the metabolite. So sometimes things are a little bit more complicated in small babies, but that's something that we as neonatologists should know. Clinical pharmacology, I think this goes back to your initial training. It's all about PK and PD. And PD is effect and side effect, so safety is included in that. So it's all about giving a given dose, attaining a given concentration, preferably in the compartment of interest, and then attaining effects, preferably without too much side effects, right? But as I mentioned, and this is just another slide to illustrate this, we have to be aware as neonatologists that things change dramatically. If a baby is born today, 6 weeks after delivery, he or she will gain 50% of his birth weight, despite the initial fall in weight at delivery. Weight will double by the 5 months and will triple in the first year of life. That's an exercise that they do not want to repeat afterwards, right? But it means that if metabolism changes that dramatically, if growth changes dramatically, that by definition, dosing of drugs, because pharmacotherapy, it's all about applied physiology, right? That this dosing of drugs will also evolve quite significantly. And there's just another way to illustrate it. Yes, we all know that puberty is associated with growth spurt, but it doesn't reach near the rates attained in the last trimester of intrauterine life and the first trimester after delivery. So things change dramatically. As a consequence, and you end up with one dose for a given drug in all your babies, that's by definition weird. It could be, but it's the outlier situation. And the second point that I want to make, and obviously I think you already know this type of concept, is that a child is not a small adult, and actually a newborn is not a small child. And the point that I made a few minutes ago, that even a 22, 23 weeker is not just a smaller preterm of the ones that you have used to take care for. So let's say that these physiological systems are different and are in need of their specific interventions. And be aware that pharmacotherapy, as we are not surgeons, assuming, is the most important tool that we have in our hands to assist babies, unless it's a ventilator, assuming that oxygen is also a drug. And we have made errors. And we go back to history, perhaps for those who are relatively new in the field, but we have killed babies in good faith by using a good drug in the wrong dose to neonates. And chloramphenicol is such an illustration. Chloramphenicol, when metabolized in the normal ways, undergoes glucuronidation. Glucuronidation, we all know that this is poorly developed in babies, otherwise they wouldn't need phototherapy, because bilirubin conjugation is also a glucuronidation process. And because babies accumulate this drug, mitochondrial dysfunction was disrupted and they ended up with what is called the gray baby syndrome, and a lot of these babies died. Why? Because the dosing was simply extrapolated from adult dosing into per kilogram dosing to newborns in an attempt to treat them with at that moment perceived to be a very relevant and potent antibiotic. So this was a first example, or one of the first examples, on not integrating what we know in neonatal physiology into drug dosing. And obviously we should do better, but these are some recent highlights based on black box warnings of the FDA that we are still making problems. And I would like to simply highlight ceftriaxone and Kaletra. Kaletra is a drug which can be used for HIV treatment and was formulated in a syrup and therefore registered for use in newborns. Unfortunately, when the drug was marketed, it turned out in the first months after its market authorization that some newborns displayed a cardiovascular collapse after this drug was administered to them, and they developed metabolic disturbances, and some of these cases even died. What was the problem? It was the excipient. A drug is made by the drug, and it's added a lot of excipients. This can be water, sodium, or alcohols. In this case, because it was a syrup, it contained quite a lot of alcohols, ethanol, and even more propylene glycol. So these babies were intoxicated because they couldn't eliminate the excipient. And only afterwards the FDA warning was adapted, and actually this drug is no longer acceptable for use, if I recall well, below 46 weeks of postmenstrual age. And same holds true for ceftriaxone. It's a potentially useful antibiotic, not in early neonatal life because it's highly protein bound and you can have problems with bilirubin. But co-administration of ceftriaxone with calcium-containing infusions, which we use commonly in newborns and commonly highly concentrated, resulted in some cases with cardiovascular collapse again, and at autopsy, because the babies died, you could find simply the precipitates of the drug and the calcium into the vessels of these babies. So sometimes we still mess up while we actually knew and should have prevented this. So what I would like to discuss with you is the first topic on pharmacokinetics, what makes neonates different. The second part will be pharmacodynamics, why are effects different in babies? And then I would like to try to translate this into how can I use this in clinical practice and how can I use this in clinical studies. As I said, it's all about maturation and non-maturational covariates. And we all take care of quite different type of babies. I showed some Olympic cases of the units that I've been working in. But if we go to pharmacokinetics, it's all about absorption, distribution, metabolism, and elimination, right? ADME. And for absorption, it's all important to realize that, for instance, gastric emptying is actually not so much maturation driven, but rather driven by the type of food you give to the patient. And if you breastfeed the baby or provide formula feeding, its gastric emptying will be quite significantly different. If you go to absorption, again, it's also about the skin. For those who take care of these very immature babies, we know that skin care is crucial and that permeability of the skin is an issue and will, as you can see on this slide, will mature quite fast after birth. So let's say the first week of life. And actually, this is the very reason that incubators have been invented. It's not because they have to be in a quiet place, but before we had incubators, babies died because of they lost too much water and ended up with hyponatremia, so too high sodium. So this skin maturation is very fast. So if you do a skin application, it's not so much the permeability of the skin, but rather the body surface area overweight, who will be the main risk factor for unintended exposure by percutaneous applications. And for instance, even for local anesthetics, EMLA type of creams, this has been described as resulting in, for instance, methylglobinemia in preterm babies. And another example is iodine-containing formulations. So that's what I wanted to say around absorption. Babies have some specific characteristics. If you consider distribution, from a PK point of view, this all has to do with distribution volume. You may still recall this from your training in pharmacokinetics, but distribution volume is to a large extent based on the physiological or pathophysiological characteristics of your patient. And if you look at this way to a baby, I used to state that the baby is born as a jellyfish. If you admit a baby today, at least 80% of this baby will be water. So if you would dry freeze a baby, you will end up with 20% of his initial birth weight. You should not do that, but that's how it is. And actually, I'm not sure if I left it, but if you have a long and prosperous life, you end up as a calamaris, because you lose a lot of water and unfortunately you gain a lot of fat. But this matters because the body composition is water. This means that especially for water-soluble drugs, your distribution volume will be different. And this is not just a technical discussion. It could be important also if you take care of these babies. Because imagine if you treat the mother with the same milligram per kilogram as her baby, the peak concentration in the mother per kilogram will be much higher because the water composition of the body of the mother is completely different compared to the baby. So your peak concentrations could be different. And besides body composition, it also has to do with plasma composition, albumin or any other protein binding capacity will be altered in these cases. And as listed over here, this means that also body protein binding in the plasma will be one of the drivers resulting in most commonly higher distribution volumes in babies. I already alluded to bilirubin, which is a specific issue in babies because we do not want free bilirubin. And if you give a drug which is highly protein bound, like for instance ibuprofen, NSAIDs, or the ceftriaxone that I mentioned, then you can end up with shifts in bilirubin, resulting in more free bilirubin, which you will not be able to quantify in the plasma because it will disappear in the brain, which is what we actually do not want, obviously. But what does it mean? Why should we bother? Not sure if there is another. Yeah. Why should we bother about distribution volume? Well, imagine water-soluble drugs, like most of our antibiotics, vancomycin. I'm not sure which type of dosing regime you use, whether you use loading dose and a continuous administration afterwards, or you go for intermittent administration. But you have to realize that because of the higher body water content of a baby, that a loading dose is crucial to attain your peak or your target of exposure as soon as possible. So if you would go for continuous administration without loading dose, it will take you about 3 or 4 days before you're on target. So by that time, you should already know whether you had to start this vancomycin anyhow, because the baby will have either died or improved, irrespective of your antibiotic administration, right? And even for intermittent administration, it makes sense to go for loading dose concepts. And the same holds true for aminoglycosides. I assume that in the UK, you most commonly use gentamicin. We at this other side of the water, we more commonly use amikacin, at least we Belgian, not in the Netherlands. But actually the physicochemical characteristics are the same. You want to attain a peak concentration for your efficacy of this drug. So again, if you look at the most immature cases below 28 weeks or the most mature cases, you notice that the distribution volume is higher in the most immature ones compared to the most mature ones, right? So counterintuitively, this means that actually you have to give a higher dose to the most immature one to reach the same peak concentration, which has to do with efficacy. Obviously, because of toxicity, you have to wait even longer for elimination, which is renally driven. So to facilitate subsequent clearance, you will have to have much longer time intervals in between antibiotic dosing in the most immature ones. So we discussed absorption and distribution. The next step is metabolism. And drugs are metabolized in general in the liver. Other organs can also contribute, lung, kidney, intestines, the brain, whatsoever. But in essence, there are 2 different mechanisms to get rid of your drug. And one is phase 1, the second is phase 2. Phase 1 is destructive in its nature. It makes the compound smaller, water-soluble, so that you can eliminate it by kidney, right? The second process, phase 2, is synthetic. It makes the molecule bigger with the same idea to facilitate water solubility and to get rid of this drug, preferably by kidney, occasionally also by hepatobiliary excretion, right? And the major progress that we have been made in the last 10, 15 years, that actually we have been able to describe all the different isoenzymes on how they mature over time or over age. And some of these enzymes you quite likely know, because these are glucuronidation. And glucuronidation is involved in bilirubin conjugation, but as well as in drugs. The chloramphenicol example that I started with, but also acetaminophen, propofol, a lot of other compounds undergo conjugation. Morphine is another one, will undergo conjugation, and this will take time. And as we know, we don't have that much habit with phototherapy in a baby of 10, 15 days old, suggesting that postnatal age is an important driver of this conjugation capacity, right? While other phase 1 metabolisms, CYP3A4 is a little bit the working horse. The current drugs on the market, if you don't know this enzyme, I usually suggest to the students, statistically your best guess is suggest 3A4, but obviously if you put questions to students, you do not only use statistics. And important to realize is all these different isoenzymes have their own specific pattern. Some of them mature very fast after delivery, like for instance CYP26, which was the one that I worked with during my PhD thesis. Others take more time. CYP3A4, it's up to the first year of life until it really matures. While glucuronidation has a fast startup over the first week of life. And it's important to know that, because this means that if a company comes to us and say, well, we have a new compound, it has potential use in neonates, so we have to study it. Can you advise us on dosing? Yes, we can. If you know how this drug is eliminated. What are the major routes of elimination? What are the minor routes of elimination? And how can we convert this into a neonatal model? And this is what I will discuss in a few minutes. This is what PBPK modeling is about. If we have the knowledge, we can use this knowledge in a clever way to make the best educated guess. And the good news is, as we all know, if you have a hypothesis, it's easy to prove or reject. But it means that we don't have to fish anymore and use an exploratory approach and say, well, let's give something and let's see where we're heading for. No, we can generate robust hypotheses, and these hypotheses can be tested to be confirmed or rejected. But that's one of the main progresses that we have made in this field. And as I said, you have to be aware that even minor routes of elimination can be terribly important in newborns, because this minor route in us adults is not yet there in babies, while the minor can already be there. And I give you this example, but caffeine is actually a very nice one. If we take caffeine, we metabolize this by the liver, right? If you give a baby caffeine, what we all do is the kidney, which is the driver of elimination, because this liver is not yet mature. And kidney is the main driver how we can get rid of this drug. And this is another example, dextromethorphan. I'm not sure if it is allowed in the UK, but at least in the US, does exist something like a healthy volunteering baby. Not sure if it exists in all legal settings. Well, sure that doesn't exist in mine. But these babies, and interesting to realize, if you look at the right panel, these babies were repeatedly exposed. So it's the same data set of children throughout the first year of life to small doses of dextromethorphan, which is a cough syrup that is no longer allowed to be given to babies. But what you can see is that the metabolic profile, how babies, or the same babies but during their infancy, handle this drug, changes completely. So what happens is actually dextromethorphan is eliminated by CYP2D6 or CYP3A4. CYP2D6 mature fast, but it's not a very potent pathway of elimination. CYP3A4 takes much more time, but is a much more potent on capacity line of working. So what you can see by collecting urine samples is that the metabolites retrieved actually switch from CYP2D6 type of metabolites to rather CYP2D6 type of metabolites over the first year of life. So that's another way to look at, by saying a baby is not just, or a newborn is not just a small child, the route of eliminations can actually be quite different. And this is applied specific to CYP3A or CYP3A4, for instance, on the plot for sildenafil clearance on the left side and fentanyl clearance on the right side. What you can see over there is you have maturation which is driven by gestational age, reflecting how mature was this baby at delivery. And what you can see is the less mature, the less clearance. That's not rocket science. But after delivery, driven by postnatal age, this clearance capacity changes dramatically. And actually it's quite interesting, because when I first was working with this data, it made me think. I'm not sure how many of you use fentanyl in your unit, but it's a more potent version of morphine. And we have the habit to increase this dosing after this baby is exposed for a few days. But with these data, you can actually question, is this tolerance? This baby needs more exposure because he becomes tolerant? Or is this simply adapting to the clearance capacity of the babies? And this is to a certain extent explored in this paper also, by illustrating the patterns on continuous infusion, depending on characteristics at delivery and characteristics once the baby is born. So again, things change dramatically while your baby is on your unit. Same holds true for propofol. Propofol, if we would be exposed to propofol, we will conjugate as main route. But babies cannot yet conjugate in the first week of postnatal life, right? And propofol is lipid. You cannot pee lipids. So how the hell can these babies get rid of it? They use the minor route of elimination, but it matters. And you can see it over here. This is a theoretical concept where you give 3 milligrams per kilogram of propofol to a baby, right? And then the drug will be cleared over time. And one of the parts you can see, a slower decrease means a lower clearance. Lower clearance in the most immature baby, higher clearance in the most mature baby. Yeah, again, that's not rocket science. But very interesting, you have two, I'm not sure if it is still there, yeah. You have two lines who are lying up each other. And who are they? It's a term baby at birth or an extreme preterm with 10 days of life. So again, things are a little bit more complicated. So what I learned from this is that propofol is a rather tricky drug at delivery or in the first days of life, irrespective of the size of the baby, because this baby will have more difficulties to get rid of this drug, so that accumulation, especially during prolonged or repeated administration, will be an issue. What I've been touching on is mainly maturational changes, but unfortunately we do not treat healthy babies, we treat sick babies, right? So non-maturational changes also kick in. And this is an illustration on how this can impact, and it's not about the absolute values, it's about the fold differences. What you can see is predicted clearance based on body weight, but also based on CRP values, so inflammatory response and organ failure. And what you can see is that a sick baby or a baby with organ failures has a significantly lower clearance capacity for midazolam. And this is important because we generally do not adapt our midazolam dosing if a baby is significantly sick or significantly in sepsis, while accumulation will occur much more likely in this specific setting. Genetics also matter. You may have heard on pharmacogenetics, but pharmacogenetics at present is mainly defined on us adults. We call something slow metabolizer or high metabolizer, depending on the adult values. But how to integrate this into neonatal practice is much more difficult because, as I said, all these isoenzymes mature over time. So whether they are genetically determined to be a slow metabolizer or a fast metabolizer, the phenotype is slow anyhow at birth and will mature over time depending on the genetic makeup of the patient. And this is illustrated for two different processes. One relates to CYP2C19, which has also a slow metabolizer profile in babies. And I think this was a study, I noticed that the references disappeared, sorry, but because they are on there. The first paper is a paper from the US group, from Robert Ward, who looked at clearance over time for omeprazole or of pantoprazole, one of the PPIs. And you can see a straight line up, which means that clearance will increase over time with maturing postnatal age. But what you can see is they have two spots, one and the second over here. Both babies were genetically poor metabolizers. But actually, in neonatal life, you cannot discriminate the poor metabolizers to the normal metabolizers, while at the age of a few months, it's quite clear that this one is an outlier. And the same holds true, but actually this is already important from birth onwards, and acetyltransferase 2, for importance for isoniazid pharmacokinetics, there's already significant difference in activities based on a genetic makeup in a baby, up to the level that this could actually affect dosing. So I discussed disease severity, I discussed genetics, but there are also other issues, like for instance, type of feeding. Very intriguingly, and perhaps associated with microfloral issues, but the way the baby is fed, breastfed or formula fed, has impact on drug metabolism. And what you can see over here is for caffeine. So if a baby is breastfed, it seems to be that the clearance capacity or the metabolic capacity for exogenous compounds matures slower compared to a baby exposed to formula. It's very intriguing, not much studies done, but it's a nice to know and interesting observation. We switch to excretion, and excretion is mainly driven by kidneys. And we know that kidneys mature over time. We express it as GFR. But we should not forget also that the tubulus is an active thing. And especially in preterm babies, I assume that you also have had these cases with metabolic acidosis at the end of the first week of life or short in the second week of life. In my opinion, this likely has to do in part not so much by GFR function, because this GFR function matures quite good from delivery onwards, but rather by the absence of sufficient maturity on the tubular function to recycle all this type of stuff. The same holds true for drugs. We have active excretion at the renal tubular level, and sometimes we have active reuptake. And these patterns have been relatively well described. And so even throughout life, you can already describe this type of patterns as, for instance, this is the clearance capacity over age for vancomycin clearance, including data in newborns. Again, babies get sick or they get treated with other drugs. And what you can see over here is, on this side of the slide, birth weight reflecting maturation until birth, postnatal age reflecting maturation since birth, and again, a fourfold increase in clearance capacity in the first month of life. That's something, again, that we never repeat afterwards. So it would be bizarre if we don't adapt our dosing regimes based on these type of patterns. In this data set, quite some babies were exposed to ibuprofen, and this meant that clearance capacity went down with 20% temporarily for these specific cases. In asphyxiated cases, clearance capacity went down on average by 40%. So knowing this, you can actually incorporate this in dosing regimes as needed. But again, as I suggested, there's more in the kidney than just GFR. It's also renal tubular activity. And I therefore have shown this, I've added this slide, because in general, renal tubular activities will mature much slower compared to GFR. And what you can see over here is amoxicillin clearance based on GFR and renal tubular secretion. But what you notice is actually the orange boxes are much higher in babies beyond the first year of life than below the first year of life. So again, showing significant differences, and again showing the fact that a small baby, a newborn is not just a small baby, but it has his specific maturational changes. If we shift to feasibility of clinical trials, I assume that you all have struggled with availability of products, right? Neonatal formulations are an issue. I already touched on excipients because we have killed babies, not by the drug, but by the excipients. But also swallowability, dosing flexibility. If you believe something of what I've said on PK, you need flexible dosing, right? But also preservatives and predictabilities are issues specific to this field. So what I've tried to do is illustrate the issues on pharmacokinetics, but pharmacodynamics also matter. And I have some illustrations, the brain, the heart. We all know that the brain matures over time, but it's not just growing, as you can see at the upper slide. It's not just making the brain bigger and more complex. Also at the fundamental level, at the level of receptor expression and receptor function, things change. So that a drug intended to work by GABA, for instance, may have completely different effects in a baby, a fetus, a baby, or an infant, simply because the receptor is there or not. And if the receptor is there, it's even so weird that the receptor can work in another way around in a newborn if compared to a baby. And this is what we have learned the hard way by the bumetanide study, which was intended to be an add-on treatment for epilepsy, but actually has been halted because of increased ototoxicity and failure of any efficacy, simply because the concept was, in my opinion, wrong. The hypothesis was to drive chloride currents, but these chloride currents are already working the other way around in newborns, so you cannot further improve this. If you look at the complex field of pain research, we use pain scores, and that's okay. But let's be honest, this is not rocket science. This is not robust. And this is illustrated by the group of Schletter, who actually nicely showed in a procedural pain model that they could not discriminate in facial grimaces related to pain or non-painful stimulus in the very tiny ones. It looked the same. Or in the bigger ones, they were able to discriminate it, while the EEG signals were more robust in their hands. So this is just one illustration. The brain is different in babies. The heart is also different. And this is illustrated at a cellular level by this slide. What I've done is explants during surgery, atrial cells in an infant, a child, and an adult. And just try to quantify EC50 and Emax for a calcium current related to isoprotenolol. And what you can nicely see is the same concentration of the same drug has completely different patterns in a newborn, an infant, or a child. So that it is not okay to simply extrapolate antiarrhythmic type of treatments from adults to newborns without additional reflections, because this cardiac function is completely different. And same holds true for toxicity. You may or may not know that QTc times are something that pharmaceutical companies worry about, because it's associated with, in us adults, with ventricular tachycardia and acute death. But QTc times in babies is a whole different ballgame. The absolute values are different. They mature over postnatal age and mature over age. And even more, if you cool a baby, QTc times even prolong further. So if you would ever have a drug that for safety reasons you would try to assess QTc time before you expose the baby, you will never be able to recruit the baby, because the normal values are abnormal if you use adult type of references. While acute cardiac collapse during whole body cooling has been described, but very anecdotal, 1 or 2 to 3 cases I've done the literature recently. And same holds true for toxicity. Liver enzymes mature over time. And the more tiny ones have more leaky livers as reference. And same holds true for creatinine. Creatinine at delivery is not only driven by the mother, but it's also driven by the newborn. So please forget the usual statement that you cannot use creatinine values in the first 3 days of life because it reflects mother. Yes, but not completely. It goes up, and the peak is most pronounced and most delayed in the most immature cases. So if you would use an ACI definition as an increase in 0.3, I can already promise that every extreme preterm will have ACI, even in the placebo group if you use a randomized controlled trial with a placebo arm, because it's their nature. I hope I've convinced you that this is an interesting field of medicine for us neonatologists, but it's not that easy. So what has changed? What tools have become available to improve our practice? I've been in the field already for 20 years or something along these lines, or perhaps a little bit longer. I tend to forget this part of my life. But there used to be a time that we tried. But actually, what this slide shows is we can try from the very beginning, from our first prescription onwards, we can do better for drugs who have to undergo therapeutic drug monitoring, because we know a lot, and we can dose better. And then when we have TDM, we can use this much clever as we used to. What I'm referring to is that actually there are software programs, medical devices on the market, and this is a work which has been to a large extent done in the UK for instance, gentamicin. And I would like to draw your attention on 2 aspects of this study. First, these are not just trough levels, right? Because otherwise all points would be at 1 point, right? So based on, we will sample any morning, or when the baby has a sample taken anyhow, much more better than wait until 2 in the night, because that's the trough level and we have to collect a sample. Again, stick the baby. But actually, if you have this knowledge and you integrate it in a software program, you can actually predict for a given patient with given characteristics, weight, age, creatinine, whatsoever, you can predict what will be the best prescription for this baby. And this type of software programs related to TDM and model-informed precision dosing are making their way by the pharmacies. I do not claim that we as neonatologists should do that, but if you have a pharmacist who comes to talk to you about this type of stuff, 1, believe him, and 2, trying to figure out how it is feasible within your unit to adapt and to further improve your practices. Second part is obviously how to improve clinical studies. And as I said, we have learned a lot, and we should try to use what we call the library, what we have as data and knowledge for future use. And you can do it two ways. Either you go by, let's say, the common way you collect data on babies, either concentrations or effects. You collect a lot of data, a lot of patients, and then you develop into what we call a population PK model, which is in essence sophisticated statistics. You can explore covariates, and you can actually prospectively confirm whether you are on the right, and in this way you can improve your practices. But obviously, if you have studied a drug by renal clearance, it reflects renal clearance capacity, so it can actually be used for the same type of compound in the next study. The second part is perhaps even more interesting for us as neonatologists. And sounds a little bit weird, but we have systems which is called PBPK modeling, physiological-based pharmacokinetic modeling. And there you construct a patient who doesn't exist in silico, or a population of patients that you usually will treat. But then you need the clinical information of these cases, and also the basic things like really how big is this liver, how much enzymes are in this liver, how much blood goes through this liver, and this type of stuff. How does kidney mature over time, how does plasma change over time? And then you can actually make predictions. It may sound weird, but the second part is actually already used for drugs which are currently on the market and resulting in SNPC or leaflet changes for us in the clinical field. So the first part is how to integrate what we already know, while we have, for instance, done this for renal clearance. If you have a model for amikacin, it should fit to gentamicin, netilmicin, tobramycin, vancomycin, or whatever type of drug who is mainly driven by GFR. The PBPK modeling is illustrated over here, and as I said, it's a little bit in silico patients. So you have the different organs, you have the different organ sizes, and the different blood streams. That's a basic. So this means that for preterm cases, and this model recently has been generated, again, also here in the UK, that these basic physiological data, they have to be provided or generated by us. So if you publish this type of data, they'll have value beyond just the beauty of science or just beyond your personal paper, because it illustrates maturational changes. And actually, the shortest in preterm babies is still longitudinal data, while we have them as a community. But this is how it works. It's a silico construct, and then you can actually make predictions. And just to illustrate, we have recently done this again with including UK colleagues to explore the basic question on acetaminophen. Acetaminophen was one of the drugs that I enjoyed working with during my PhD by accident, because at that time we already had IV formulation on the market for 20 years, but nobody ever studied it in our country. So that was called an opportunity. But our basic question is, how should we dose acetaminophen in a baby with a significant patent ductus? Right? And the stupidity was at that time, the study was already initiated to do so. And by accident, we confirmed each other's findings, but if they would have been unlucky, they may have used the wrong dose. But what you do then is you make a construction, you make an adult model, you make a baby model, and then you check it. The thing that we have done is that, yes, we have a baby model, but we have a sick baby. So the perfusion of the organs could be different. And what if cardiac output changes with 20, 30, or 40%? Will this affect clearance? This is what I've illustrated over here. It doesn't affect clearance down to 30% reduction. And this has to do with the type of drug. We are doing now the same exercise for propofol, because propofol is a high extraction drug, and our hypothesis is that there you will find the signal. But we know a lot, we can do a lot, and actually can in this way improve also studies before initiation. So how to integrate this knowledge for clinical studies? You can reduce the number of observations by extrapolating. And as I said already, it's all about generating a robust hypothesis, because as you have a hypothesis, you can prove or reject. But you need much less data. And actually, you can even also do the study design clever and say, well, for this drug, we think that sampling at around 6 hours after administration in a few cases and 18 hours after a few cases, that this will provide us the most information, be it with very limited number of data. So from an ethical point of view, it also reduces significantly the burden. Obviously, you can play around by trying to figure out other type of matrices, high sensitive techniques and this type of things. We need patient relevant outcomes. Because to refer to the patent ductus, to be honest, I don't mind whether the ductus is closed or isn't closed. If I were a parent, I would like to know, will my child go home with respiratory or central nervous system related issues, right? And PDA closure may be a surrogate marker for that, but it's just surrogate, right? We need to harmonize definition and outcome. I will illustrate this based on a recent commitment of your Prime Minister to change some things in your country. I will illustrate it by quantifying adverse events. Adverse events are a lot in babies, but it's important to realize that if you have an adverse event in a clinical study, you first have to decide on seriousness, and that's purely a legal issue. Is this baby dead or not? That's a robust outcome variable and general dichotomous. Is this prolonged stay in the hospital? Much more difficult in a baby. Pregnancy, not an issue, right? Remaining long-term neurocognitive outcome, that's difficult because you can prove that the baby has an intraventricular hemorrhage, but how this will affect long-term outcome, we don't know at that time. So the seriousness, be it legal, has some issues. And something different from that is grading severity. And this may be technically, but imagine that you have, for instance, again, to go back to the PDA system, you have some people who believe in ibuprofen, other in paracetamol, and a third group who still believes in indomethacin, right? They all have side effects. On kidney, ibuprofen and indomethacin both have renal side effects. So it's all about quantification. We as clinicians need to know how much more likely is it that something will occur when I decide A or B. That's what we need severity grading for. And causality is even more important. And this is what I refer to with Boris Johnson, because if I understood it right, he wants to go back to another metric in your country. But there is an error described on that at the end of the last century. While UK and the US was collaborating on an orbiter to be sent to Mars, and it went well until the landing was started, then it crashed. And in retrospect, the problem was the metrics, because UK people were still using English units, and US people used the generally accepted metrics. So it's an illustration just to show that we have to agree on definitions, because otherwise we are comparing literally apples with pears. I cannot make any robust statement. Severity grading has also been done recently as an effort in Inc., because this generic system was really made on adults, daily activity of life. But what the hell is the daily activity of life in the preterm? So we worked on that to further improve this. And I come here at the end of my talk. I hope you learned a little bit on what makes neonates different if you focus on pharmacokinetics, what makes them different on pharmacodynamics and safety. And I try to illustrate this on how this could be of relevance in clinical trials. Thank you very much.
Thanks very much, Karel. That was a fascinating overview of the trials and pitfalls that we all face every day with our patients. We do have time for questions. Chris, you've got your hand up. While the microphone's coming, could I just ask a quick question? What you're pointing to very clearly is the need for a sort of personalised approach.
Right.
To all of our patients. How far off do you think we are? Because it feels at the moment that we're a million miles away from a truly personalized.
But technically, we are very close by. We only, quote unquote, need integration. And I had this discussion recently also with German colleagues and with other colleagues that thank you for the information, but we cannot use this in our unit because it's too complex. I still believe that neonatal care as a perspective should learn from Formula One. Because you have the driver, and I like to feel that the neonatologist is the driver, right? He's a key person of the system, but he believes his engineers. Or he tried to integrate the information he gets from a lot of type of resources to make the best available decision. But what we need over there is much more integrated software programs, because what we have now is, yes, we can add another screen with another type of information, but this is not the way it works. So I think it's all about integration. We have a lot of tools available at present, but we need more integration, and this will be a major effort.
Sure. And what about the role of AI in all of this?
Well, yeah, but AI will not provide the solution, it will provide answers. I mean, there's a lot of, also from pharmacokinetics, AI seems to be more performant. So I truly believe that this is an add-on value. But again, this AI, to implement AI will be the major burden in neonatal care. And as I said, the only thing that I think is that we will have to redesign the way we work and more go into an integrated system where we get the information as needed. As for instance, also you have warning systems on potential sepsis and all this type of stuff. But if it is a disconnected system from your main system, you lose half of the potential of this type of systems. So good idea, but we need a clever design.
Yeah. Okay, thank you. Chris.
Thank you, Karel. I mean, just fantastic and so much detailed information. And my take-home message is that we all need a Professor Karel Allegaert to discuss every treatment option that we think about taking. And I mean, on that note, reflecting back on the huge number of variables that affect whether a drug is the dose that you give is correct for the particular baby, the circumstances. Do you think that the reason we maybe have so many drug trials which don't show benefit is related to the fact that we are often using just one dose in a whole very varied population of babies, and that actually we're not seeing benefit just because we haven't thought about the dosing, we're not dosing these treatments correct effectively. And then kind of just to reflect a bit on that as well, and Keynote, I think, is another example. This is a drug that was clearly tested with a pediatric investigation plan, from what you were saying, and still it wasn't detected that there was a potentially lethal outcome from the excipient. So how do we tailor those two things together? How do we test drugs in a way that is going to ensure that babies that receive them at the right dose, but also pick up the potentially devastating side effects? Because we're clearly not doing it yet, are we?
Mm-hmm. Yeah, that's the key question, obviously. You have, on the one hand, the beauty of science. And that's beauty, you can publish about it, and that's the advantage of PK. You have data, you can publish them. But then how to translate it into clinical care, you have to focus on clinical meaningful differences. Like, for instance, for aminoglycosides, you can still use them in an asphyxiated baby, but you have to extensively extend the time interval. And we can provide information on how much more extended this should be, right? So this is one part of the answer. I agree that neonatology is by definition noise. And you refer to randomized controlled trials, but this is on efficacy. Once you subsequently implement this type of practices in a real world clinical setting, you either further add noise. So this, to a certain extent, likely suggests that we do have limitations, and then we have to make selections on what we are targeting for. Being aware that you may know, but in the European setting, and I think UK is still involved in this type of problems, is the pediatric investigation plan means that drugs have to be developed also in pediatrics that are relevant for this specific population. That even there we are much less robust on neonatal data. For instance, on antibiotics, labeling change for meropenem or whatsoever. We only need some PK data, some safety data, and that's it. And for the rest, we extrapolate from adults and children. But this means, again, that we need actually much more post-marketing type of data. So I'm actually responding, but not replying to your question, because I'm fully aware that this is a very sophisticated and very complex system. And just to refer to your question on lung maturation, we have just done a study also in pregnant women. PK of lung maturation in the mothers is completely different whether they are preeclamptic or not preeclamptic. So, and again, whether they weigh 60 kilogram or 180 kilogram, it's one dose fits all. So it's quite some work to do, sorry.
So do you think some of the trials which have been negative, to put, to use a bad word, but, trials that have not shown benefit, is that due to the dosing? If we ran that trial with effective dosing, would we find that lactoferrin is beneficial, for example, or? It
could be, like, for instance, the big morphine trials on ventilation. I've been discussing the last days with some colleagues on that. We have intoxicated these children, so why would we see differences? These doses were 5 to 10 times higher than what we currently use in these patients. So if you intoxicate a group, then the likelihood that you will show benefit in this group may be outweighed by the side effects, right?
We have another question from one of our online guests, Dr. Ros Carr from Wiston Hospital in Merseyside. So thank you for an interesting talk. May I ask, generally speaking, in day one, UNE and creatinine is thought to be from the mother, but you said that there's not black and white.
Yeah, it sounds a little bit posh or impolite, but I would suggest to read the text that we wrote on that in Neonatology a few months ago. But it's quite interesting because creatinine in the pregnant mother is relatively stable between, if I recall well, 32 weeks onwards, while actually creatinine in babies goes up. So the more mature the baby, the higher the creatinine at delivery. And we have to think on that, likely because the muscle mass in this baby increases, and that's the source of creatinine. So there are different variables, but actually we can already discriminate at birth based on gestational age or birth weight, what are reference values in these babies. So it's from birth onwards, and we have just reported on 1,000 cases with asphyxia undergoing cooling, and also over there this creatinine in the babies is significantly higher from birth onwards. And if you think about it, it has to do obviously that the placenta, while mothers behave by their placenta as their fetus is a puber. This means she cleans up all the mess, right? So any creatinine which is generated by the baby or by the fetus should be eliminated by the mother. But at late pregnancy, it could be that the blood flow and the capacity of the placenta is not fully there yet to get rid of fully creatinine synthesis. So my answer is actually you can already discriminate from birth onward, but obviously let it be clear that if the mother has renal failure, that this will be reflected in the fetal. So we are only talking our normal reference values of these babies.
So the last bit of her question was, how early can we say the blood result accurately reflects the babies?
I can promise you that you can do it on actually at birth if you would like to. And then it's all about what we try to develop for creatinine is a little bit Z-scores. I mean, there has been a presentation on growth charts. So why would we not develop Z-scores of growth charts for creatinine over time in these babies? And in this way, you can actually really display trends and normal trends of creatinine or outliers in the one or the other direction. So you can actually do it from birth onwards. I'm not sure if you need it for your clinical decision. That's another aspect. But technically, it should be available for interpretation.
Okay. any other questions? The last question over there. John McIntyre from Derby.
Thank you for a fascinating talk. I'm interested in your thoughts. As a neonatal community, should we have a checklist of high priority drugs to revisit with PK/PD data? And if so, what would be on your hit list to revisit to get things better?
Yeah, this has been attempted 2003, 2004 by priority list at EMA. And if I recall well, there was some energetics over there, but actually it didn't brought a lot of results or effective output. I think what I usually do is simply look at pediatrics, but with an X, reports regularly on their drug prescription or drug utilization data. And there you have the top 100 of drugs used in any baby, in preterm babies. So I think the most commonly used drugs, I think we have solved the PK part on antibiotics to a large extent, but it's all about implementation. And new emerging drugs, which is a common practice in neonatology. There's something new in the market, and let's try it, like for Dexmet. Is perhaps another one, but you should try to focus on which is most commonly used, and perhaps we should mainly focus on real world data and show what and how we use and try to compare between units to what extent it may be associated with difference in outcome.
Okay, Karel, thank you. You've got us all reflecting on our own practice and thinking of.
Good.
Thank you so much. I'm sure there'll be an opportunity for more questions during lunch. Thank you to all of our speakers this morning's sessions. I'm sure you'll all agree with me. We've had a really great start to our meeting, and I'm looking forward to the afternoon session. We now have lunch, which will be between now and 2 p.m. So if you could come back promptly at 2 p.m. all sat down ready to go, that would be great. Lunch is where the coffee was served. Please visit the sponsors. There's a group of sponsors who are in a separate room from where the refreshments are, and they're feeling a bit lonely, I think. So if you could make a point of going to see them as well, I'd be very grateful. The sponsors do make a huge difference to our ability to put these meetings on, and it's very important that they see you and you have chats with them. So thank you for that. So I'll see you back at 2 o'clock. Thank you very much.
Thank you. Could I just also quickly add, if you have parked your car on the university site, you need to put the permit that we gave you into the car with the registration and use the Ringo app. You need to do both of the things so that security will know that your car is meant to be here. Hopefully everybody's done that. Thank you.
Otherwise it will be destroyed. Otherwise.